Hello and welcome to the Headache Doctor podcast. I'm Dr. Taves, joined again by Dr. Storsbach. And as always, it's our mission to educate and empower everyone with headaches and migraines to break free from a life of fear and dependence and thrive in everything that you do. And something that's come up more recently, and we have a connection with a few dentists and orthodontists that's in this area, and we feel like is going to be very pertinent to you, the listeners, is sleep apnea and sleep, how that impacts headaches and migraines, the connection there. And so we're going to go through and talk about sleep apnea so that we can better understand what treatment approaches are out there. And we're going to tie that back into, of course, as always, what we do here and how we might interact with someone that has sleep apnea. And then hopefully you guys leave here, leave this podcast thinking about your sleep. Maybe there's some things that are going unnoticed, because this is one of those areas that maybe in general providers don't necessarily have it on their radar, like your primary care doc or something like that. And but it could be an issue. We have patients that can be more challenging patients that I think understanding their sleep and potentially they have sleep apnea can be a really good route to go down if their headaches or migraines are being more stubborn, or if this tension pops back up. So it's pertinent to a lot of people, especially those that have headaches and migraines, because there could be tension that's built up at night. And then if you have headaches or migraines that tend to pop up in the morning, that puts you in sort of a higher risk category for having disrupted sleep in some way. And we'll talk a little bit about that. But really anyone with headaches and migraines, this is going to be good information for you. So we have an outline here. We're going to start out with just talking about what sleep apnea is and defining that.
Yeah, so sleep apnea, like you said, is disrupted sleep. Apnea technically means kind of like a stopped breathing for 10 seconds or more. And there's a few different types of sleep apnea. There's obstructive sleep apnea, which is the most common form. It's when the throat muscles and like the soft palate really relax and actually narrow or completely close off the airway. So then your brain has to wake you up and get more air in. But the thing is, some people, your brain can do that, wake you up and you not know it. So again, it's not like you always remember those instances, and they can happen several times throughout the night. Then there's central sleep apnea, which is a little more rare. It's mostly just when your brain doesn't send the proper signals to your muscles that you control your breathing. This is a little more common with neurological issues and strokes, things like that, but it is possible. And then they have added a third type, just called complex sleep apnea, which actually has both. So both obstructive and central. So that's sleep apnea in a nutshell.
Yeah, those are the three types. So we're probably going to lean more on the obstructive sleep apnea side of things.
Exactly.
Yeah.
Mm-hmm.
Okay, so we have some like general risk factors that might be helpful for people,
Mm-hmm.
and so this will kind of define who's at a higher risk of developing sleep apnea. And so as we go down this list, if you check multiple boxes here, then again, especially pertinent to pay attention and maybe take action on this after we're done talking.
Mm-hmm. Well, I first here have like a checklist of things to kind of go through, and then we'll talk about risk factors too.
Yeah.
But this is kind of good to just kind of, again, go through this checklist. If you have several of these, it might be worth checking out with your doctor. The first one is loud snoring. It is good to note, though, not everyone who snores has sleep apnea, so there is that caveat. And again, cessation of breathing while you're sleeping, meaning 10 seconds or more, you are not taking a breath. Reports from probably another family member or partner in the room of you gasping for breath while you're sleeping. Insomnia, meaning you're just not sleeping well at all. Morning headaches is on here. Decreased libido, tooth grinding, irritability, exhaustion during the day, difficulty paying attention, high blood pressure, depression, obesity, and large neck size are all on here. So that's kind of a nice checklist to go through. And there are also, actual risk factors to make this more common.
Real quick, we'll stay on that because you said teeth grinding, and one of the things that we notice actually quite a bit, and actually working with some of the dentists we work with, they've illuminated a problem that a lot of people have in this clenching, grinding bruxism, it wears down people's teeth, and that wear and tear on the teeth. So my point here is that you might not realize that you're clenching or grinding, but there will be signs and symptoms of it. Tension through the jaw, wear of your teeth in certain patterns. And I mean, whether you want to try to evaluate that yourself, or if you feel like you can, great. But I would suggest, talk with a dentist. Make sure that you fully understand if you're clenching or grinding your teeth at night, because that could lead you down the road of understanding, okay, maybe I do have some sleep apnea, or maybe there's just tension, or I need to improve my bite, that type of thing. So some of those things they're not obvious to people. And I would say actually the opposite, like most of the time they go unaware. Like people are unaware that they're doing those things. And so good to have a professional sort of speak into that.
Definitely, and I would say dentists and orthodontists are like kind of front line for health providers that tend to see this the most or diagnose this the most. So definitely, if you're seeing your dentist, make sure that you're having that conversation with them. But yeah, back to risk factors. Definitely excess weight and obesity is a huge risk factor for sleep apnea. And the neck circumference, like certain, centimeters for males or females. Anything larger than I think 17 or 16 males or females can be a risk factor. It just, genetically inherited narrow throat, enlarged tonsils. Being males are 2 to 3 times more likely to have this than women. Being older, so as you age, also can be a risk factor. Family history, of course, use of alcohol, sedatives, or tranquilizers, which is kind of like this catch-22, because a lot of these people will say, well, I can't sleep, and so they'll start taking something to sleep, but they're still not getting deep sleep because they're waking up. Smoking, smokers are 3 times more likely to have obstructive sleep apnea. Nasal congestion, so allergy problems. And then there's other medical conditions that are kind of related with this, like heart failure, high blood pressure, diabetes, things like that.
Yeah, so that's a really good, the checklist, and then who's at risk. And so again, if you check multiple boxes there, then definitely pay attention. But even if you don't, this is still something that really everyone has to make sure that they're getting enough sleep. And we'll go into a little bit of that later as well. But how common is this as far as like sleep apnea itself?
So specifically for obstructive sleep apnea syndrome, this is observed in about 3% of middle-aged populations. And actually, but within that 3%, the prevalence of a sleep apnea headache in this population is, they think, between 12 and 18%. So that's just good to know. Again, 3% is actually a pretty big number, like 3 out of 100 can have this, and then within that, definitely there can be a correlation to morning headaches.
Yeah, definitely. Okay, let's bring this into like the connection of sleeping and headaches, just to give it some context for people out there that maybe don't think that they have a sleep problem, but do have headaches and want to make sure, like, well, what's the connection if I did have a sleep issue?
Yeah, so there's a few, connections. In 2018, there was a headache sleep study done where migraine sufferers are far more likely to report poor quality of sleep, now not specifically sleep apnea, but just a very poor quality. And then therefore, poor quality of sleep tends to intensify migraine pain, meaning making it worse, more intense. And they have noted that lack of REM sleep, so we have different phases of sleep, which we can dive into if we have time, but REM sleep specifically is where when that is lacking in your sleep cycle, that can trigger or be a risk factor for migraines. And then even too much sleep can even increase your risk for migraine. And so again, these people who sometimes have really poor quality sleep actually will sleep more to try to get into those phases, but actually sleeping more can also raise your migraine risk.
Yeah, let's go into that, because let's go into the stages of sleep, because it's important to understand that just closing your eyes and waking up, it's what happens in between there, and it doesn't look the same for everyone. And so again, these are things that you may be unaware of, And so there's indications of when you wake up, if you still feel fatigued, if you have tension, if you have a headache, those types of things can indicate that you didn't get a good night's rest. But what does a good night's rest look like?
Well, so there's, like I said, 4 stages of sleep, and we go through them multiple times, and they each should kind of have a certain length of time, and they all kind of have different functions on our body, and they're all important for rest and recovery and cellular repair and memory function and things like that. So the first stage is just called, so there's basically 3 non-REM sleep or stages and 1 REM. And I feel like everyone kind of knows REM, like eyes can, go back and forth. We can have dreams in that stage. But stage 1 is also called N1. It's normally only that 1 to 5 minutes where you're basically starting to doze. And sometimes people's bodies will twitch. You can easily wake up in this stage. And again, it's very short. But then that brings you to stage 2 or N2. And this can last anywhere between 10 and 60 minutes. As the night goes on, this stage, as you repeat through it, gets a little bit longer and longer. And then we have N3 or stage 3. This is the deep sleep. Again, very important for cognitive function and retention of long-term memories. This can last anywhere between 20 and 40 minutes. And then the last stage is the true REM sleep. That can be anywhere between 10 and 60 minutes. And this is where your rapid eye movement back and forth can occur and dreams can occur. So yeah, those are the 4 stages.
Yeah, and so how would that be interrupted? How would those stages be interrupted? And why would someone not be able to get through the stages?
Exactly. Yeah. So yeah, as you can see with those time frames, a lot of times people with sleep apnea can wake up upwards of 30 times a night. And so you can imagine they might get through 1 to 2 stages, but enough minutes have passed that their body has started to become apneic or slowed their breathing to the point that their brain has to wake them up again. Even unconsciously, they'll take a breath and they'll have to go back through the stages. And so they never actually get to that 3rd and 4th deep sleep, REM sleep, which is kind of the most important. And they'll do that over and over and over again. And they could still, quote unquote, be sleeping through the night, but they're never getting into their good phases. And the research definitely shows less REM sleep can be a huge trigger for migraines.
Yeah, that, and then the length of time that they're in each stage, mm-hmm. right? So that's important as well, where let's say you get to REM, but you don't get a full, what could be like 60 minutes upwards. Yeah. And so it's the percentage of time spent in that REM sleep and then the length of time in REM sleep, or even in that deep sleep stage, that N3 stage. And so it's getting into the stage and then how long you're in the stage, right?
Exactly.
Okay, and then the airway being interrupted is a big part of that because it triggers our brain to kind of wake you up because you need to breathe.
Yep, important.
Yeah, that's easy to understand and it makes sense because I think people say sleep apnea, but maybe we don't fully understand what's happening or how that can impact how we feel when we wake up. So that's good. Okay, so from here, let's talk about maybe some more research, connecting that into headaches. What type of headache? I think we've got a couple studies on like tension type headache versus migraines. So let's go through those.
So we have several articles we looked at, and the big takeaway from like large reviews of articles was that tension type headache is the most commonly associated with sleep disturbances. There was a great study here of 143 participants, and ultimately the conclusion was the patients who suffered from tension type headache were more likely to have insomnia and sleep disruption than patients just with migraine or controls. And nearly all the patients with tension type headache had very poor sleep quality, which was also observed in approximately half of the individuals in the migraine and control groups. So honestly, all of them had sleep disturbances, but the most highly correlated was the tension type.
Yeah, okay, so here's where we are going to apply our understanding of neck tension playing into headaches and migraines and speak into this a little bit. So when it comes to a tension type headaches typically present as like pain that can start from the shoulders and the neck, and it'll kind of wrap up and around, and oftentimes it's in the temples and the forehead, just kind of a strap in the front of the head. Now, tension type headaches are they're labeled tension type headaches because there's a lot of tension, like muscle tension, and we know that muscles behave in a way where throughout the day, oftentimes we can drown out, sort of like ignore, not pay attention to a pain signal from a muscle. So muscle soreness, things like that. We can go about our day and not give it as much attention as maybe it wants. And then as we try to fall asleep, if the muscle is angry, that's when it's hard to ignore it, because our brain is settling down, we don't have distractions, and we're trying to fall asleep, but these muscles are irritated. And so there's sort of a discomfort, unsettledness, and we have a tough time falling asleep. And so the tension type headache, if I'm going to sort of rationalize what that study found, I would say that's likely part of what's going on is the muscle tension that these people are experiencing is keeping them from getting into those deeper stages of sleep. And it could be something where, if we think about the cycles of sleep, maybe they are falling asleep enough to, when they wake up, they think they've slept, but their body has enough tension running through it that they are just sort of tossing and turning, or they wake up slightly, that sort of thing. Mm-hmm. So as far as tension type headache, that's sort of the direction I would take in explaining that or rationalizing through that. You think that's fair?
I think that's very fair. Yeah.
Yeah. Okay. So let's talk about so if we're going to have someone come in that has sleep apnea, that has headaches, migraines in the morning, what's our process going to look like potentially, and then how might what we do help impact that, especially if it's the first type of sleep apnea where it's obstructive?
Mm-hmm. Well, we definitely will still look at the neck. We talk about the neck a lot, but we will still look at the tension in the joints and muscles of the neck, and then definitely in the jaw too, with that potential for that teeth grinding, and again, waking up with headaches can just be driven from jaw tension. So really making sure we're looking at both of those things. And then if they truly have had a sleep study and say, I have sleep apnea, it's good to always follow up with what treatments they're actually doing for that, who's following them. The gold standard is a CPAP machine to help them have that positive airway pressure during the nighttime. But then there's also a lot of dentists who will do oral appliances at night that pull their jaw forward. And that's, again, another reason we should always be looking at the jaw to make sure that appliance is, not pulling on anything too much during the night. And then there's some orthodontists that will do even full jaw surgery, or what's called maxillary skeletal expanders, where they kind of put screws in your palate and open up the nasal passage that way. So there are a lot of treatment options, so maybe talking to them about that, see what they're doing. But on our end, what's nice about us is we get to see them so regularly, we can constantly check in with what they're doing, what's working, what's not, and then making sure that we're addressing the true neck, muscle, shoulder, jaw tension as they go along.
Yeah, the way I would look at this is there's a couple different things that play into. So if someone comes to us with sleep apnea, and so their airway is obstructed at night, there's several different avenues that we can take. Now, there's a chance that maybe in their development, their jaw was just not shaped or formed in a way that allowed it to mature to a level that just physically allows them to breathe properly at night. And so that's where orthodontia, these surgeries, maybe come into play to actually increase the airway, physically increase the airway. Now that's one approach. The other approach is, as someone is sleeping, what position is their jaw in? And are there things from a musculoskeletal perspective that are causing that jaw to rest in a position that's not catering to allowing a proper airway? And in that scenario, that's where we come in, and we would work on the neck, work on the jaw, trying to improve the airway, reduce tension through the jaw, because we know that the neck and the jaw work hand in hand. If the neck has tension through it, one, because it's so close in proximity, but a lot of these jaw muscles interact with the neck. And then the jaw is, it's more free floating than not. I mean, it has two joints and it's a single bone. And the tension that it would receive is these muscles are anchored to the neck itself. So if the neck is not resting in a proper position, then there's naturally going to be tension through these jaw muscles. And so the jaw might not want to rest in, I guess I'd say, a neutral position. And so that's where we would come into play. So we would want to treat the neck and the jaw and see what happens. See if this tension reduces, see if we can get the patient sleeping better. And we've seen that quite a bit. I mean, we have patients frequently that tell us they can sleep better. They have more restful sleep. They're not waking up with headaches. I can think of a few off the top of my head that are on our schedule currently. Whether they were actually diagnosed with sleep apnea or not, it's a part of that picture. And so we feel like the neck tension, jaw tension scenario is a really good avenue, especially if you want to avoid something like a surgery that's a little bit more invasive, maybe less comfortable. We were just talking about the screws and the tension that they place through those. It's really nice to have that as an option, but it just sounds like something we want to take a few steps before we get there, type of thing. And that's where we come in, is where our approach can be, it can be a conservative approach, and if it helps, even if it helps to an extent, then we know we have something here. And then if we need something else to get you across the finish line, that's where the orthodontia and dentistry can come into play. So a few takeaways, unless you had any other thoughts there.
No, great thoughts. I mean, one random thing that I keep thinking about is a lot of my patients who don't sleep well will be taking melatonin. So I just want to put that plug in there, because a lot of people immediately go, I don't sleep well, I'll just take melatonin. And that's fine, but you want to make sure it's actually, you start at a very, very low dose, like even 1 milligram, and every 3 weeks you should take a full week off. Almost all my patients are like, yeah, I take melatonin. I'll say, well, how long have you been taking it? Oh, maybe a couple of years, and I'll say, well, do you ever take breaks? And they'll say no. And that's a problem, because the melatonin is naturally produced in your brain, and we do need to have our brain do that on its own versus supplementing it. So if you take melatonin, please start small, take some breaks, really do maybe a little more reading on it, because it's not like this quick and easy. Even though I know it's over the counter, people think it's safe, something you should think about.
All right, so a few takeaways in addition to that is, if I could have everyone listening to this do a few things, I guess what I would say is, next time you visit your dentist, ask them to evaluate your teeth and if they see signs of wear, okay? Now this could be an indication that you're grinding or clenching your teeth at night. And then I also, now take that information, you can go down the route of potentially trying a night guard, things like that. Night guards can they're either gonna protect your teeth, but they're also going to improve your bite, which, it has implications potentially in sleep apnea. But that clenching or grinding can be an indication of maybe you need to go further down this, like, how am I sleeping avenue. The other thing is, if you wake up and you don't feel rested, or if you have a headache in the morning, again, something else to evaluate as far as how you are sleeping. And then the steps from there, if you've been listening to this podcast and you're thinking, I think this is me, I think I either have sleep apnea, I have issues sleeping, I get headaches in the morning, well, evaluate your position that you're in. So don't sleep on your stomach, things like that. If you're listening to this and you're still sleeping on your stomach, and this is the first time you've heard me say that, just know that that's a very important thing. We have patients come in that have terrible migraines, and that's the first thing we will talk about, and they'll switch their sleeping position to their side of their back, and they'll improve quite a bit. But finding treatment after that. Now, if you're in Colorado Springs, we'd love to work with you. It's probably going to be easier to find a center that focuses on breathing and airway, like an orthodontist or a dentist, and you'll likely want to find sort of a specialist in that area. So it's general dentistry. They should have a level of understanding to sort of point you in the right direction, and then they can hopefully send you to a specialist. But if you know, like, this could be a major player in your story, then that could be a good avenue, especially because clinics like ours are not as prevalent. And so it might be good to pursue that from like a sleeping perspective and improving your airway. So those are just some take-homes. Any other thoughts, Dr. Sturzbach?
One easy thing, I've had several patients have Garmin and Apple watches that actually can take their oxygen levels at night. And I'm not saying, I don't think they're FDA approved, I'm not saying they're perfect, but it gives you some feedback. And so if you're looking at that and you're dropping below 90% consistently of your oxygen saturation levels at night, that is something that I would go and talk to either your primary care, your dentist, or orthodontist about, and get it checked out.
Yeah, absolutely. Good thought. All right, so there it is, sleep apnea, sleep, the importance of it, how the neck plays into it. Thank you all for listening to the Headache Doctor podcast. As always, it's our mission to educate and empower everyone with headaches and migraines to break free from a life of fear and dependence and thrive in everything you do. Thanks for listening.